Good evening all. We'll start at sharp 7 o'clock. Good evening. We'll start at 7. Good evening everyone. Good evening Dr. Sharma. Good evening Subhash. Good evening V. Whatever V stands for. Of course, victory. Good evening Narayan. We'll start at sharp 7 o'clock. So 2 minutes from now, we'll wait for everyone to join. All of you, you can just type in how you're feeling. How is everything going for your Neet PG preparations? Let me know, and then we'll start at dot 7 o'clock. One more minute to go. So how is everything? How is your Neet PG preparations going on? Okay, we have Pediatrics residents also joining us. Welcome, Dr. Datta. Good to see you here. Don't be anxious for INICET or Neet PG, guys. Whatever we taught you in the classes, you just need to remember that. Just keep on revising, keep on giving your grand tests and your CPTs. Okay? I'll just check my audio and my computer. So it's 7 o'clock. All of you, welcome to Medskool. And today we'll be talking about pediatrics. And what we'll do is I will be talking about a baby who is lethargic at home. So our theme of the day today is a floppy baby. And what I'll show you that in your exams, everything comes around a baby who is hypotonic, a baby who is floppy. So we'll go as the case comes in our hospital. You know, a baby comes to us and the parents say that, sir, our baby is floppy. Our baby is, whenever we feel the muscles, we feel the baby is very floppy. The baby has no tone. Baby is always lying in the bed in a frog-like posture. So this baby is lying in the bed in a frog-like posture. So we call this as a floppy baby syndrome. Okay, so we call this as a floppy baby syndrome. So defined as a baby who is hypotonic. Now the causes of a floppy baby, anyone, any guesses? So our theme of the day is floppy baby, and we'll show you that everything, multiple questions in your exams revolve around a floppy baby. So any guesses? Guys, we want to be interactive. So any guesses you can shoot. So Sahil, you may be right, but you know, there are many causes of hypotonia in a baby. Remember, there are many causes of hypotonia in a baby. So it can be right from the central. So it can be a problem of the brain. So it could be a central hypotonia. It could be a problem of the spinal anterior horn cell. It could be a problem of the neuromuscular junction. Or it could be a problem of muscles. So what we'll do is today we'll talk about right from the brain to the muscles, what are the causes of a floppy baby. So let's start from the brain. Let's talk about central causes of hypotonia. So central causes of hypotonia, all of you, is the most common cause in a baby all over the world. In fact, the most common cause, all of you mentioned about costly, rare syndromes in the chat box. But guys, the most common cause of hypotonic baby is HIE, hypoxic ischemic encephalopathy. Other causes can be some injury right at birth, intracranial hemorrhage, chromosomal disorders. So many chromosomal disorders, even Down syndrome for that matter. So Down syndrome causes hypotonia at birth. Many metabolic disorders. So a baby who was born normally and over the next few days, suddenly this baby becomes hypotonic, lethargic because of accumulation of substrates. So this baby can also be hypotonic because of some metabolic disorder, which can be urea cycle disorder, organic acidemia, mitochondrial disorder, even some neurometabolic disorders as well. There are many CNS metabolic disorders which may cause hypotonia at birth. So all of you, what we'll do is we'll make it interactive, and I'll keep on talking about what MCQs come in your exam. So my first question to all of you is, what is the most common cause of a floppy baby? All over the world, what is the most common cause of a floppy baby, guys? And I want all of you to write in the chat box. And the answer is let's see who answers first. And so Sahil, actually in Edwards syndrome, there is hypertonia. So remember, Edwards syndrome in fact has hypertonia. And everyone is right in the chat box. I can see chat box running. And yes, HIE, hypoxia, is the most common cause of a floppy baby. Remember this. Let's show you a case, guys. So let me show you a case of a hypotonic 6-month-old baby. So all of you, now you have to tell me. Remember, this is in fact a very common case scenario for Neet PG, for INICET exams. A 6-month-old baby who is hypotonic. And this baby has hypothermia. This baby has hypothermia. This baby has constipation. Umbilical hernia. You can see umbilical hernia on your screen. This baby has a history of prolongation of neonatal jaundice. So this baby, when the baby was 1 month old, this baby had neonatal jaundice. So even at 1 month, this baby was having prolongation of the neonatal jaundice. And this, I said this is a 6-month-old baby. This baby has delayed development. So all of you, these are key features of, and everyone in the chat box is right. All of these are key features of congenital hypothyroidism. You are completely right. The most common preventable mental retardation all over the world. Congenital hypothyroidism. The most common preventable mental retardation all over the world. And you're right. I can see many students typing in the chat box that these babies have widely open fontanelle. So congenital hypothyroidism may have delayed closure of fontanelles, widely open fontanelles. So let me ask you important questions. Remember, newborn screening is available, should be done all over the world. So every baby in the world should get which test? What test should be done in every baby of the world, guys? What test should be done in every baby of the world? And the answer is TSH. So every baby in the world should get a TSH. So of course TSH should be done. Now my second question is, what is the best strategy? Is TSH alone, or we should also do a T4 with TSH? Guys, what is the best strategy? TSH alone or T4 with TSH? TSH alone or T4 with TSH? So ideally, there are many countries in the world who have a lot of money, So T4 with TSH is the best strategy, but not every country in the world has money for doing both. So ideally, we should do both, T4 with TSH. Okay, let's go further. Let's ask you when and how to do TSH. What is the best time, guys, to do a TSH? Can anyone tell me in the chat box, what is the best time to do TSH? And how? My options for you are cord blood, 24 hours of life, 48 hours of life, 72 hours of life. What is the best time? Cord blood, you just go to the mother's side, you take the maternal cord sample, 24 hours of life, 48 hours of life, or 72 hours of life. So remember, all babies at birth, within 30 minutes, the TSH rises. So the best time to do TSH is after 48 hours. Okay, so day 3 of life. So even your OP Ghai textbook says day 3 to day 5 of life. Okay, day 3 to day 5 of life. By a heel prick. Okay, not cord blood. No, Mrinal, how will you find cord blood at 48 hours? It has to be heel prick. So after 48 hours of life, on day 3 of life, we do a heel prick. Okay, noted all of you? After 48 hours, day 3 of life, by a heel prick. Okay, this is also the time to do TMS. We also do TMS in babies for metabolic disorders. So for metabolic disorders, for inborn errors, we do a TMS, tandem mass spectrophotometry. So what is the best time to do TMS? After 48 hours of life. Now this is very, very, very important, guys. What is the most common cause? So can anyone tell me? What is the most common cause of congenital hypothyroidism? Anyone? What is the most common cause of congenital hypothyroidism? And I can see Dr. Nidhi typing in the chat box. She's right. 85% is dysgenesis of the thyroid gland. So 85% of the times thyroid gland is not formed. Okay, so 85% thyroid gland is not formed. Okay, so thyroid gland is not there. So okay, let's ask you a question which is not important, but in all of our lectures, we say boys have so many problems, boys have so many issues in life, nobody understands. But guys, can you tell me, congenital hypothyroidism is common in boys or girls? Anyone? Congenital hypothyroidism is common in boys or girls? And the answer this time is, it is common in girls. In fact, the ratio is 2:1. So somehow congenital hypothyroidism is more common in girls with the ratio of 2:1. Now, what is your first step? And in fact, this question came in Neet PG 22. What is the first step if your TSH is high? What is the first step if a baby's TSH is high? The first step, if the baby's TSH is high, is a nuclear scan to look for the thyroid. We want to locate the thyroid. So the first step is a technetium-based nuclear scan. Okay, a technetium-based nuclear scan. But suppose your examiner, shows you a TSH which is very high. All of you remember the cutoff of TSH is 20. But if your examiner shows TSH of more than 80, suppose he shows TSH of 100, what will be your first step? Suppose your examiner gives you a baby whose TSH is 100. Remember, do not wait for the investigations. Start thyroxine. Remember, if we have a society in our country called ISPE, Indian Society of Pediatric and Adolescent Endocrine, ISPAE. So Indian Society of Pediatric and Adolescent Endocrine says if TSH is more than 80, please start thyroxine. Do not wait for the investigations. Otherwise, this child, his brain will not be developed well. He will be mentally retarded. So later you start the therapy, more will be the risk of mental retardation. So all of you, can you just write in the chat box and like this video that you understood these 6 questions so that I can go further. All of you? Cool? Can you just show me a thumbs up in the chat box? And let's go further. Now from central hypotonia, let's talk about peripheral hypotonia. And let us talk about spinal anterior horn cell. Spinal anterior horn cell. Let's talk about a disease of spinal anterior horn cell called autosomal recessive spinal muscular atrophy. Autosomal recessive spinal muscular atrophy. It is a disease of the spinal motor neuron. Okay? A disease of the spinal motor neuron. So guys, can anyone in the class tell me what will you see on the examination? Anyone? Lower motor neuron lesions or upper motor neuron lesions? Anyone in the chat box? If there is a lesion of the spinal anterior horn cell, what weakness will you see? Upper motor neuron or lower motor neuron? Lower motor neuron weakness. Element, lower motor neuron weakness. So what you'll see is, you will see atrophy, flaccidity, areflexia. So all of you know from your medical school, lower motor neuron means atrophy, areflexia, flaccidity. And let me show you a video. Let's see what this video shows. Now this is a video of a baby who is floppy, and all of you, can you tell me what can you appreciate on this video? Anyone in the class, can you tell me what can you appreciate in this video? This baby is a floppy baby, and I'm showing you the fasciculations. You're right. Can you see the trembling of the tongue? Can you see the fasciculations? Can you see the trembling? So fasciculations is a feature of spinal muscular atrophy. Remember guys, fasciculations is a feature of spinal muscular atrophy. SMA. Remember, fasciculations are best appreciated at the tongue and the deltoid. Fasciculations are best appreciated at the tongue and the deltoid. Look at this baby. How is this baby lying down? Can you see? Completely hypotonic. Legs are completely abducted, outwardly rotated. Can you see there is no tone? See, when we are looking at the tone, the bulk is less. There is complete hypotonia. There is no tone in the baby. Classic of spinal muscular atrophy. See, this baby is so hypotonic, so miserable. This baby cannot move. Okay. So guys, what is the inheritance of spinal muscular atrophy? I want all of you to write in the chat box. This is the in thing, guys. You should know this. So the inheritance of spinal muscular atrophy is you're right, Dr. Nidhi. He was lying completely in a frog-like posture in the bed. What is the inheritance? Autosomal recessive. You're completely right. SMA is autosomal recessive. Why am I talking about SMA? Because even our Delhi Chief Minister also knows about this, because recently our Delhi Chief Minister there is a gene therapy now available for this disease, and the gene therapy, single injection, remember, single injection treats the disease. If you give this injection early, single injection treats the disease. Okay, so this is Kejriwal ji, and this is written in Hindi. I know I should not speak in Hindi because residents from all over the country are here, but it is written 17 करोड़ के इंजेक्शन से बच्चा हुआ ठीक, 18 महीने का बच्चा मिलने पहुंचे केजरीवाल जी. So this child was treated by the help of Delhi government, and okay, let me write in English here that this injection saved this kid with the help of our Delhi government. So this is the world's costliest drug available for this disease. So single injection. So gene therapy recently been approved and successful for spinal muscular atrophy. So all of you should know the name of 3 disorders and 3 drugs. So the name of the drugs is nusinersen, onasemnogene abeparvovec, which comes by the trade name of Zolgensma. As doctors, we are not supposed to, talk about the drug labels, but this drug, you should know the company name also, Zolgensma, Zolgen SMA, and risdiplam. So nusinersen, yaad karna hai, all of you. Okay, this is not a movie going on, guys. Whatever I am telling you, you are supposed to know this. This is the in thing, guys, right now, that the gene therapy is successful for this disease, and we see every month we get patients like this in our hospital. And yes, it's the world's costliest drug called Zolgensma, which is around 17 crore rupees. So these 3 drugs are called the disease modifying drugs. Okay, they modify the gene. So SMA is an autosomal recessive disorder, mostly because of the deletion of the SMN gene. Remember, all of you, did you note the name of the drugs? Did you note the name? Or shall I go back? Remember, so you should know the first name was, it's a single dose, single injection, Dr. Ekadashi. Single injection cures the disease. Okay, it's a one-time 17 crore, okay, not every month. So nusinersen, you should know, it is an antisense oligonucleotide. Okay, please remember this, you have to remember, because for your exams you should know these are the new revolutions in science. Okay, nusinersen is a antisense oligonucleotide which modifies the splicing of the gene. Just remember this sentence, because in your exams they will definitely ask you. Nusinersen is an antisense oligonucleotide which modifies the splicing of the gene SMN2. Now let's talk about the drug used in Delhi. Onasemnogene abeparvovec. Onasemnogene abeparvovec. It replaces the mutant SMN1 with the normal SMN1. Just remember these single sentences. They will help you to solve the answer in your exam. Onasemnogene abeparvovec replaces the mutant SMN1 with normal SMN1. Risdiplam is a small molecule SMN2 splicing modifier. Just note down these things. I'll wait for you guys. Very important. Risdiplam is a small molecule SMN2 splicing modifier. So basically, they treat the gene at the level of gene. They correct the genetic defect. Okay, and these 3 drugs act at different levels. Just remember and note these single sentences. Please note down in your chat box, in your copies, please open a notebook, guys. So nusinersen is an antisense oligonucleotide which modifies the splicing of the SMN2. Onasemnogene epiparovac replaces the mutant SMN1 with normal SMN1. Risdiplam modifies the splicing of the SMN2 gene. So problems are in these two genes, SMN1 and SMN2 genes. Please remember that, don't forget. Okay, noted? Noted? Please note it down, very important for your exam. This is the in thing, guys. It comes every day in the newspapers these days. All of you just write cool in the chat box so that I take you to the roots. So anyone, what is the root of nusinersen? Nusinersen is given intrathecal. Remember, nusinersen drug is given intrathecally. Zolgensma, called onasemnogene epiparovac, is given IV. Dr. Nidhi, onasemnogene epiparovac is a single IV infusion, okay? Don't say every month 17 crore lagege, aisa nahi hai. Single injection. So nusinersen is intrathecal, onasemnogene epiparovac is a single IV infusion, and risdiplam is oral. And risdiplam is oral. Okay, so let's take you now from the lesions further below. Now from anterior horn cell, let me take you to neuromuscular junction. Okay. So you have to remember these names. Okay, someone in the chat box is saying, "Sir, ये नाम कैसे याद होंगे?" बेटा ये नाम तो याद रखने पड़ेंगे. Okay, this is the revolution these days. You have to remember these 3 drug names. Okay. एक बार फिर से you just repeat yourself, like I can say, see, onasemnogene epiparovac is the world's costliest drug. You should know this. Okay, and the roots, Dr. Surbhi, risdiplam was oral, onasemnogene epiparovac was single IV injection, okay, and nusinersen was intrathecal. So let's take you to neuromuscular junction now. Let's go below, guys. And in neuromuscular junction, the problems can be myasthenia, congenital myasthenia, or infantile botulism. So botulism toxin also works at the neuromuscular junction. Okay. So all of you, I have a long MCQ for you. Can you please move your devices to the landscape mode and look at this question? I'm sorry for a long clinical question. I'm so sorry for this crowded slide, but let me read with you. A 5-month-old baby, 5-month-old, mind you, this is not a newborn, not a 1-month-old child. It's a 5-month-old child. And this 5-month-old child has refusal to feed, weak cry, constipation for the last 2 days. This baby was born completely normally. And even the perinatal and postnatal periods were uneventful. So it does not look like SMA. You know, SMA babies are even, there is decreased fetal movement in the antenatal period also. So this does not look like SMA to me. This baby was feeding well. SMA doesn't feed well. This baby was completely normal till 4-month-old. So till 4 months, this baby was completely fine. Now this baby has weak cry, weak sucking, head lag, bilateral ptosis. Note, point to be noted, ptosis. Dilated pupils with sluggish reaction to light. Okay, sluggish reaction to light, hypotonia, decreased stretch reflexes. So guys, let me ask you, what is your diagnosis first? So let's look at the chat box, what everyone is typing. Divya, this is not hypothyroidism. Hypothyroid baby will not have ptosis. Can you see, ptosis was it was a marker telling you something. This baby was not hypotonic right from the birth, feeding well. This is not hypothyroidism. Someone just deleted his comment. So this is not hypothyroidism. Hypotonia. A baby who was 5 months old. Point to be noted, 5 months old. What happens at 5 months? Mother starts complementary feeds around 6 months, So this baby could be an infant botulism. And remember, infant botulism is diagnosed by demonstrating the botulism toxin in the stool. Okay, so infant botulism is diagnosed by demonstrating the stool evaluation, and we look at the Clostridium botulism in the stools. And how do you treat, guys? Anyone in the chat box? How do you treat botulism? So there's a specific immunoglobulin for botulism available. So we treat it by giving a specific immunoglobulin for that. Okay. So guys, ptosis was very important. So this is in fact a girl with myasthenia, what I'm showing you. So myasthenia patients may have ptosis. They may have diurnal variation, that even in congenital myasthenia, you may have a history whenever baby wakes up, the cry is good. But in the next half an hour or in the next few hours, the cry becomes weak. So there may be a diurnal variation, ptosis, in neuromuscular junction disorders. Okay. So this baby is also TUN. Now someone in the chat box wants me to say, so today our theme of the class is a hypotonic baby, a baby who's TUN. Hindi mein kehte hain TUN. So let's go further. So remember, if you talk about myasthenia, so here is a child with myasthenia, a disorder of the neuromuscular junction. This baby has completely expressionless face, ptosis. Now, when we gave them, there was a response to cholinesterase inhibitors. So when we gave them cholinesterase inhibitors, their eyes improved, their expression improved. So there was a response. So even response can also help you to understand that this patient has myasthenia. So remember, let me take you back here. So disorders of the neuromuscular junction can be myasthenia, congenital myasthenia, or infant botulism. So guys, let's go from neuromuscular junction to muscles. So last point of the day, let's talk about muscles. And please guys, listen to me carefully. Duchenne's muscular dystrophy does not present at birth. Remember, Duchenne's does not present at birth. So Duchenne's does not cause a floppy baby. Okay. Your exam will have a question on Duchenne's, but today we are not talking about Duchenne's. So Duchenne's does not present at birth. It usually presents in boys at 2 to 4 years of life. Now today we are talking about a floppy baby. Congenital muscular disorders. Congenital muscular dystrophies. Congenital muscular or myotonic dystrophies. So guys, I have a pedigree on the screen for you. And you will have to tell me the diagnosis. Okay. Okay. So everyone, here is a pedigree. This is a very peculiar pedigree. Of course, this is autosomal dominant. There is no doubt about this. All generations are affected. Males and females are affected equally. This is autosomal dominant. But my question to you guys is, So, Dr. Jan, botulism may also have a history of honey being given to the baby. Honey is very common in infant botulism, Dr. Jan. Coming back to this pedigree. So, this baby is floppy at birth. You can see this boy on the right side. Now, his mother has a problem of grip. Whenever she tries to hold a grip, she's not able to hold well. She's not able to release the grip. She has a grip problem. That's it. And now, look at the grandmother. The grandmother just cataract. Grandmother has just cataract. So guys, my question to you is, which phenomena is exhibited here? Nobody is telling me the right answer. You're telling me the diagnosis. I'm asking you which phenomena is exhibited here. Which phenomena? Anticipation. So you can see, I will tell you 3 sentences. With every successive generation, disease becomes severe. Number 1, with every successive generation, disease becomes more severe. Number 2, with every successive generation, disease presents early. So you can see with every successive generation, the disease presents early. Okay, I said becomes more severe, presents early, and number 3, with every successive generation, the repeats increase. You can see the trinucleotide repeats are increasing with each generation. So with every successive generation, the repeats increase. And yes, you're right. The diagnosis is myotonic dystrophy, congenital myotonic dystrophy. So guys, please note down anticipation. With every successive generation, the disease presents early, becomes more severe, and the repeats, the trinucleotide repeats, also increase with each successive generation. So this is a classic myotonic phase. So this is a baby who came with floppiness. And guys, can you appreciate the upper lip? Can you see an inverted V upper lip? This is a classic upper lip of myotonic dystrophy. Remember, this is a classic upper lip of myotonic dystrophy. Inverted V upper lip. And look at the temporal areas. There is loss of the temporal muscles. Okay, loss of the temporal muscles. Okay, inverted V upper lip, loss of the temporal muscles. Let's talk about this child's mother. I said his mother is a problem of the grip. So guys, are you ready to look at her grip? How she holds? Look at her handshake, okay? So guys, on your screen is a video showing a normal handshake. This is like a normal handshake, like we always do. A normal handshake. Now let us look at this mother's percussion myotonia. If you percuss at the thenar eminence, you see a myotonia. Can you see? A classic percussion myotonia. When you percuss the thenar eminence, there is percussion myotonia, a feature of myotonic dystrophy. Now, ask her to hold your grip tightly. Grip release test. Let's look at the grip release. Hold my fingers as hard as you can. Now release. She cannot release the grip. Can you see? Myotonia. Incomplete relaxation after a contraction. So on a grip release, you could see that the mother had incomplete relaxation after contraction. So she had a grip problem as well. Okay. So this was the classic mother who had mild features of myotonic dystrophy. So guys in the class, can you please type in the chat box, inheritance of myotonic dystrophy. Guys, it has to be two-way communication, okay? We are not talking about putting recorded lectures on an app here. We are talking about two-way live interactive sessions. So Medskool is at 7 o'clock on YouTube is all about live interaction, guys. So I want you to tell me The inheritance of myotonic dystrophy, and everyone in the class is right, it's autosomal dominant. Okay, I'm proud of you guys. So remember, trinucleotide repeats, CTG. So myotonic dystrophy is CTG or CCTG repeats. More are the repeats, more severe is the disease. Okay, so more are the repeats, more severe is the disease. And it presents early. Okay, cool. Now all of you remember, in your every exam, whether it's INICET, you get a match the following. In INICET, you get a match the following. So one of the option is trinucleotide repeat disorder. So remember, Fragile X is also a trinucleotide repeat disorder. CGG repeats. Remember, Fragile X is X-linked. CGG repeats. More are the repeats, more is the mental retardation in boys. Friedreich's ataxia, GAA repeats. Spinobulbar muscular atrophy, CAG repeats. Spinobulbar muscular atrophy is CAG repeats. Huntington's chorea, CAG repeats. Spinocerebellar ataxia, CAG, or CTG repeats. Please remember the name of these trinucleotide repeat disorders. You need to know this. So please remember the names. Myotonic dystrophy, Fragile X, Friedreich's ataxia, spinobulbar muscular atrophy, Huntington's chorea, spinocerebellar ataxia. So all of these disorders exhibit anticipation. Remember, all of these disorders exhibit anticipation. By which I mean that the disease becomes more severe with every successive generation, presents early with every successive generation, and the repeats increase with every successive generation. Cool? All of you, can you just write cool in the chat box? So we can now talk about the approach. Let's talk about the approach to a floppy baby. Let's talk about approach to a floppy baby. So all of you, again, on the screen, you can see a baby with inverted V upper lip, completely expressionless face, a typical cartoon of myotonic dystrophy. Because of the weakness, these children may have abdominal respiration. So because of the weakness of the respiratory muscles, they may have abdominal respiration. Okay. So how do we examine this baby? So when we examine, and all of you in your clinics, when you examine this baby, the first test is pull to sit. I'm pulling the baby to sitting position, and can you see the head is lagging? This shows hypotonia. Pull to sit position, there is hypotonia. So let us show you a video of a baby who is completely hypotonic, how we examine this baby. Let's look at this baby, guys.
Lift up her head while lying on her belly. Does your baby seem floppy? When you pick up your child, does it feel like she will slip out of your hands? Can she lift up and hold her head during tummy time? Most babies can lift their heads briefly, turning them side to side within the first month of their lives. They can typically lean on their forearms or push up from their belly at 2 to 3 months of age. This baby is an infant, just a month or so old, but still has no ability to hold her head. Instead of moving their head side to side, a baby with SMA may follow you with her eyes, rather than respond to you by turning her head your direction, as this baby does, keeping her head only to her right, or whatever direction.
So could you see? This baby was not moving, is completely in a frog-like posture in the bed, and is following you with the eyes, but not moving his body. Okay, typical case of a spinal muscular atrophy. So the signs of hypotonia are, of course, on your screen is a normal baby. Look at the head. This baby is able to hold the head in the plane of the body. And on the right side, you can see a completely floppy baby, no tone, no head control, completely floppy. So the first step is we pull to sit. The second is on horizontal suspension. You keep the baby on horizontal suspension. You can see complete floppiness on horizontal suspension. Now the second is vertical suspension. Guys, when you pull, I will show you a baby today again. So when you hold a baby in vertical suspension, guys, the baby doesn't slip from your hands. Baby, you will be able to hold a baby. But if you have a baby of floppiness, because of whatever be the cause, on vertical suspension, the baby will be slipping through your hands. So on vertical suspension, if there is a shoulder slip through, so on vertical suspension, if the baby is slipping from your hands, it is also a marker of floppiness. Vertical suspension, shoulder slip through. So on your screen, guys, to summarize, on pulling to sit, on pulling to sit, you can see head lag. On your right, you can see a scarf sign. We are just putting the baby's hand towards the other side, and can you see the hand has completely gone to the other side? There is so much hypotonia. So this is a scarf sign. Completely slipping on vertical suspension. You can see horizontal suspension showing complete hypotonia. So on your screen are different signs of hypotonia. Pull to sit, scarf sign. On vertical suspension, baby is slipping through. And on the right below section, you can see on horizontal suspension, the baby is completely floppy. So guys, how do we differentiate it's central or peripheral? So of course, if there is altered sensorium, it is central. In peripheral, whether it's neuromuscular problem, muscular problem, spinal motor neuron problem, baby is alert. Okay. In central, baby can have dysmorphic facies. Today I showed you a dysmorphic myotonic dystrophy. Peripheral are usually not dysmorphic. Okay. Central, they have problems of the facial expression. They are mostly axial. So the central muscles are more involved in axial, in central causes. Like if you see a baby of HIE, the baby is completely hypotonic. While if it's just a muscular problem or a neuromuscular problem, they are more of distal muscular problem. Central may have abnormal delay, mostly motor milestones are delayed. Peripheral have profound weakness, while in central there is complete developmental delay. And last but not the least, guys, that's the crux. In upper motor neuron lesions, you will get hyperactive reflexes, while on the right side, in lower motor neuron lesions, areflexia, fasciculations. Mark my words, very important. Fasciculations are lower motor neuron. All of you, are you with me on the same page? Can you just type in the chat box? You're with me on the page or somewhere else? So these Medskool at 7 p.m. is to keep your tempo up, guys. Okay, so that we see you every day and we talk every day about some important points. So everyone is with me. So I have a question for you guys. This is a pattern question which came in INICET exam. So my question to you is, fasciculations are seen in which disorder? I want all of you to tell me the answer. Okay, I will not tell you the answer. You have to tell me. Fasciculations are seen in. And Everyone is right, of course. I can see chat box buzzing. Spinal muscular atrophy. So in spinal muscular atrophy, fasciculations are seen, lower motor neuron weakness, which are best appreciated at the tongue. So dysmorphic features are very important. So guys, what if I show you this child? What if I show you this child on your screen? So what do you see on the right side? What if I show you a baby who has small hands and feet and obesity? Guys, what will you think of if I say a baby has small hands and feet, hypotonia in the neonatal period, neonatal hypotonia, small hands and feet, and genetic obesity? What will you think of? Neonatal hypotonia, small hands and feet, and obesity, hypogonadism later on. Prader-Willi syndrome. So even Prader-Willi, guys, so today I summarize all the floppy babies. So even a Prader-Willi baby also has floppiness at birth. So what are the features of Prader-Willi? Small hands and feet, neonatal hypotonia, and later obesity, hypogonadism. Remember, Prader-Willi is the most common syndromic obesity all over the world. Remember, Prader-Willi is the most common syndromic obesity all over the world. So how do you diagnose? What is the inheritance of Prader-Willi? So all of you should know that 70%, I will just talk about Prader-Willi today. So 70% of Prader-Willi is because they get deletion from the PA. PA. Can you see PA? So there is a micro deletion 15q11 to 13. So there is a micro deletion called 15q11 to 13. 15 long arm, 11 to 13. 3 exons are missing. So if you get the deletion from your PA, child gets Prader-Willi syndrome. And if you get the same deletion from your Ma, child gets Angelman syndrome. So in Hindi we say Ma. So this is just to remember, deletion from the Ma causes Angelman, and the same 15q11 to 13 deletion. 15q11 to 13 deletion causes Prader-Willi syndrome. So remember, 70% of Prader-Willi is because of genomic imprinting. So all of you, question for you. What are the 2 inheritances of Prader-Willi syndrome? All of you, question for you. What are the 2 inheritances of Prader-Willi syndrome? 2 inheritances of Prader-Willi syndrome. So I said 70% is genomic imprinting, where they get the deletion from the PA, and 30% is unimaternal disomy. Unimaternal disomy. So remember, there are 2 inheritances of Prader-Willi. 70% is genomic imprinting, where I'm sorry about my N, imprinting, where you get the deletion from the PA, and 30% is unimaternal disomy. Cool? Yes, you're right. Everyone in the chat box is right. And I'm proud of you guys, all of you, for attending all of these lectures attentively and being with me in the class. Good. So on your right side, we showed you that what are the features of a myotonic dystrophy, a floppy baby, uterine dystonia. So even they may have uterine dystonia, difficult delivery, problem of the handshake in the mother, they all suggest myotonic dystrophy. Okay, so uterine dystonia, difficult delivery, inability of the mother to relax her handshake is myotonic dystrophy. Okay. So that was all for the day, guys. So today, what I wanted all of you to know that remember, if you get a floppy baby in your exam, the causes can be right from the brain, okay, to the spinal motor neuron, to the neuromuscular junction, to the muscles. So remember, there are multiple causes, and this is the approach you should have for a baby with spinal muscular atrophy or any other cause of a floppy baby. Okay, so do remember to revise these lectures and revise these golden points. These are very important points for your exam, and I, on behalf of the DAMS team, wish you all the best, guys. I hope you find all of these lectures useful, and I'll see you on the other side. Right now I'm in my clinic in the hospital, so maybe I'll see you someday on the other side when you are a postgraduate and I am a grumpy consultant scolding you in the rounds. Thank you and all the best.